Okay, good morning, everyone, and welcome to this Friday morning's meeting. Presentation by the Gastroenterology Department by Dr. Pascal Kuka, one of our supernumerary fellows from Kenya. He's going to present an interesting case that we're currently managing in the department, which we hope will stimulate a lot of discussion from everyone. Thank you.
Okay, thank you very much, Neo Seabi. So we're going to discuss about ulcerative colitis in an unusual site. We're saying unusual because we ask ourselves, can ulcerative colitis, a disease that has the name colitis on it, can it occur anywhere outside the colon? Is it a yes or no? And we'll find out that both answers might actually be correct. So we'll just begin with the background of IBD. As we all know, there's some concepts that we all learned in medical school, third or fourth year medical school, about the differences in UC and Crohn's disease. So although some of them hold water, but there are some nuances that more and more as you develop to the profession, you get to learn that could be a bit differences. For example, we talk about ulcerative colitis occurring from the rectum, going proximally, as opposed to Crohn's disease, which are skip lesions and they can occur anywhere in the GIT, all the way from the mouth till the anus. But then we also find out that sometimes ulcerative colitis can actually be pancolitis involving the rectum and the colon all the way into the cecum, and occasionally can also have what is known as backwash ileitis, where you actually have inflammation within the terminal ileum. And then although the general principles are that inflammation in UC is mostly mucosal, but patients can present with severe acute UC, where you get transmural inflammation leading to complications like perforation. The main typical presentations for UC are rectal bleeding, and you shall see the other presentations in the subsequent slides. In terms of histology, there are some subtle differences between the two. Both might show features of chronic inflammation, but then granulomas are mostly associated with Crohn's. That's why one of the big differentials for Crohn's disease is actually tuberculosis, and that kind of marks the waters in terms of diagnosis. Although crypt abscesses is one of the features of UC, it can also occur in Crohn's disease, and it doesn't have to occur in histology for you to come up with an impression of ulcerative colitis. So as you see, there are so much differences in either the two of them. But we also have an entity called IBD undifferentiated, where we can't swing either way in terms of deciding whether it's IBD, whether it's UC or Crohn's disease, and the management becomes a bit complicated in that. So still, specifically about ulcerative colitis, so the presentation, as I say, is a typical presentation of rectal bleeding and increased frequency, as well as the urge to pass stools. And other than bleeding, patients can also present with a mucoid stool. So there isn't any gold standard diagnosis of ulcerative colitis, but it is a constellation of your clinical presentation, your findings on endoscopy, and suggestive labs, as well as histology that we've seen can be suggestive of IBD or ulcerative colitis. So, I mean, the pathogenesis of IBD, there are different factors that come into play. So the main things that we talk about are genetics, environmental, immune dysfunction, and the gut microbiome. So it's important to understand some of the concepts because, as we'll see, some of them might be supportive in our case and some of them might actually be a bit in dispute. So about 8 to 14% of patients with the IBD have a primary relative with IBD as well. And there's lots of work that has been ongoing in terms of trying to identify the genetics, which, I mean, can predispose patients to having UC or IBD. These are important, especially in the era of precision medicine. We're trying to find out which particular patients can be targeted for some of the advanced therapies. The immune dysfunction forms a big part of the treatment. There are some targets that we've been able to identify that we utilize for part of the treatment. Some of the cytokines like TNF, interleukin 23, are actually targets for treatment. And then there is treatment targets that actually try and prevent T-cell homing into the GIT. Environmental factors are also well described. One, whether having infections, GIT infections in childhood predisposes you later on to getting UC or Crohn's. There's a role of diet and also smoking as an interesting relationship in IBD. in that it can actually be protective in UC, but is a risk factor for developing Crohn's disease. And then the role of the gut microbiome, it's been shown that there are some commensal bacteria which are elevated or increased in numbers in IBD, versus there's a decrease in some of the others. We look at the environmental factors a bit in a subsequent slide. So this is just documentation of some of the things we've talked about. So whether UC or Crohn's is actually a factor in the colon lumen, but we all know that eventually it leads into this, cytokine-mediated immune dysfunction and causing destruction of the mucosal and the other layers within the GIT. So they said we have some targets for treatment like TNF, interleukin 12, interleukin 23, and also we can prevent lymphocyte trafficking into the intestines by utilizing some of the advanced therapies that we'll also have a look at. So I talked about environmental factors. So there is an interesting study that looked at, as you know, because of historical factors, we have a lot of people of Indian descent all over the world, because of historical and colonial factors. So they looked at the incidence of this particular group of people with Indian ancestries all over the world to try and see whether there's any change in the incidences depending on where someone is. As we know, South Africa is well represented in terms of Durban, which has the honor of being the city with the largest Indian population outside of any city in India. So they looked at, let's say, the incidence of UC in Durban. That was about more than 30 years ago, unfortunately, where they found the incidence to be 2.7% compared to the incidence in places like Leicester in the UK or in Canada, where it was found to be more than 3 to 5 times the incidence. So they actually think about whether the people who moved to the Western countries adopted a Western style of diet as opposed to people who, in Durban, who maybe they still use some of the not traditional, but some of the cuisines from the ethnicity in terms of India. But I say that's just a postulate. There could be other things that are also at interplay. So why are you so concerned about ulcerative colitis? So although sometimes you can present with just inflammation within the rectum, but the disease can evolve even with treatment. Like you can initially can present as proctitis, but later on can evolve to involve the colon, and therefore having complications like gut dysmotility. Quality of life is an important issue, especially in terms of treatment, because active disease can actually impair the quality of life. And then some of the things that we fear about in terms of hospitalization, just like any other condition, but also the need for colectomy, which can happen in uncontrolled disease or complications like dysplasia or even malignancy. Colorectal cancer is a huge risk in ulcerative colitis, which increases with the disease time, the time that someone has the disease for a long time. So, this is a very simplified treatment for ulcerative colitis, but we divide the severity into mild to moderate or moderate to severe. And the cornerstone of treatment is the 5 ASA agents. And we also use steroids, but important to note that steroids are not used for long-term for either Crohn's disease or ulcerative colitis. In cases of patients who require steroids or patients who are not responsive to steroids, then we change them to steroid-sparing therapies like thiopurines or methotrexate. But then there's also the concept of advanced therapy. So in terms of moderate severe disease, patients don't have to earn an advanced therapy. If patients present initially with moderate severe disease, then they can actually straight on be initiated on advanced therapy. But of course, in our setting, we are very much limited in terms of availability of the advanced therapies. So when you talk about advanced therapies, what exactly are they? So we have 2 main classifications where I have the biologics and the small molecules. So in terms of anti-TNFs, as one of the biologics is one of the most commonly used group of drugs, infliximab. It was the first biologic that was initiated, for treatment for ulcerative colitis, and still till now, in most places of the world, is still the most commonly used biologic. The other groups include anti-integrin, which has one in the group, which is vedolizumab, but the other drugs in the group which are used in other conditions like natalizumab, which is used in multiple sclerosis or which was used before in multiple sclerosis. Then we've talked about targeted therapy for anti-interleukin 12 and 23, where initially you have ustekinumab, but you have more other drugs in the pipeline, including mirikizumab and risankizumab. For the small molecules, we have tofacitinib and upadacitinib as part of the JAK inhibitors. And the other group is the sphingosine 1P inhibitors, which have etrasimod and ozanimod. So having looked at the background of IBD and UC, we'll now focus on our case. So this was a 28-year-old female who presented with a history of bleeding, rectal bleeding for about 5 months with increased frequency of stool, passing up to 6 to 8 times stool per day. And she also complained of fatigue and dizziness and a bit of palpitations. And she had a history of weight loss for, about 6 kgs in the same period of time when she had the symptoms. So on further system inquiry, she also had vaginal bleeding with no history of any discharge. Some of the initial evaluations showed vessels which were stable. She was pale and she had a low BMI of 19. In terms of further inquiry, she had a family history of IBD in the brother and the mother, and she was of sober habits, and she didn't have, she's not used to smoke any cigarettes. So on doing a past medical history, that's when things start getting a bit interesting. So although I mentioned that she's female, she's actually a transgender female who had undergone a bit of, lots of interventions before that to look when we talk about the past medical history. So as I said, she presented to us this year, but she had undergone gender affirmation therapy, consisting of both hormone therapy as well as surgical therapy. So the initial hormone therapy involved the testosterone suppression with use of gonadotropin release agonist, and she also started on supplementation with estradiol in terms of increasing estrogen levels. She then underwent reconstruction surgery, which we'll see the details in subsequent slides. And after that, she's been maintained on estradiol supplements as well as bone health medications. So important to note that at that point when she's being evaluated for reconstruction surgery, she didn't have any of the current symptoms that she's presenting with now. So we'll have a bit of look in terms of gender affirmation therapy. So there are two main forms of treatments. It can be hormone therapy and surgical therapy, and patients can choose whichever way it suits them. So more and more people who are gender diverse, or people who are transgender, are seeking these therapies for gender affirmation. And it's been shown that these treatments can actually improve the mental health in terms of reducing the suicide rates, as well as just improving the general well-being. So as I said, the treatment, it's hormone and surgery, but there are some evaluations that's supposed to be done. The most important evaluation that should be done in patients who are being started on hormone therapy is to look at some of the effects of reducing the primary hormone as well as increasing the supplementary hormone. So for example, for patients who are patients who are being put on testosterone therapy, for example, female to male changes, they need to, make sure that they don't have hypertension, they don't have sleep apnea, because I think some of the things that can be exacerbated by testosterone therapy, as opposed to patients who are being male to female, converted, who one of the risks of estrogen therapy is thrombosis like DVT or any other sort of thrombosis. So that's part of the evaluation that needs to be done. In terms of surgical therapy, it's only to deal with the genital surgery, but there are other forms of surgery in other places of the body which we're not going to look at. So specific for male to female gender reassignment surgery, it can be different forms of surgery. So you can either have phalloplasty or vulvoplasty or vaginoplasty. And then for patients who also wish to undergo gonadectomy, they also undergo orchidectomy. So it's important to note that there are some patients who undergo one or two more of these procedures, depending on how much they will want to have the transformation to be ongoing. So we've talked about evaluation for hormone therapy. What about evaluation for patients who are willing to undergo surgical therapy? So one, they have to be proven that they actually have gender incongruence as opposed to having gender dysphoria. So part of the evaluation is mental health evaluation. And some of the guidelines recommend that patients need to have evaluation by at least 2 mental health professionals. And of course, they also need to have undergone informed consent, but that is a bit in dispute, especially in areas of the world in which children who are prepubertal are actually evaluated for gender affirmation surgery. So as I said, that's still in dispute in other areas of the world. And then patients need to understand the effects of the surgery on subsequent reproduction. In cases where it's possible, they're actually supposed to be offered fertility sparing treatment, so that in case they will want to, undergo or conceive, or in case they want to, have children in future, that can still be done. And then they also need to have had at least 6 months of suppression of testosterone and having been in the gender role for the same period of time. So what about contraindications? So severe psychiatric or physical comorbidities are contraindications. And in case of vaginoplasty, smoking and an elevated BMI are also considered contraindications. Specifically about intestinal vaginoplasty, patients not need to have had either previous extensive surgery or a previous history of malignancy or even active IBD. So the options of vaginoplasty, there are different tissues that can be used to recreate the new vagina. So you can either use the native penile tissue, you can use part of the intestines, or even skin grafts. So more and more, the use of the intestines is preferred in vaginoplasty because there are some advantages that have been shown to accord. So one of them is that because it has a natural moisture, and also because it has an adequate length, it's been shown that patients report good outcomes in terms of using colon vaginoplasty. So important to note that these surgeries are not only performed for patients who are transgender, but also patients who have some sort of congenital anomalies, for example, vaginal agenesis or introitus stenosis. These are some of the patients in which have undergone these treatments before. So some of the data have been gotten from this particular group of patients. So specifically about intestinal vaginoplasty. So what exactly is done? So these are just some of the pictorials. So they resect a section of the sigmoid, but important to note that the resection of the sigmoid, they preserve the peritoneum that is attached to that. So they preserve the blood supply to the same. And then that part of the sigmoid is further manipulated to kind of pull it down to the pelvis. And at the same time, they're also performing perineal surgeries. So it's done by two sets of surgeons. So there's gender or colorectal surgeons who perform that, as well as people who are specialized in terms of perineal reconstruction. So the other part is the laparoscopic representation of what is happening as well in the cartoon pictorial. So some of the complications of intestinal vaginoplasty. So intra-op, other than all the other complications of surgery, the most common one is rectal injury, occurring up to 35% of patients. And then long-term complications include neovaginal stenosis, which sometimes might require frequent dilatations. Because of the surgery, patients can also develop rectovaginal fistulas and prolapse. And one of the key long-term complications, just because of manipulation of the urethra, is recurrent UTIs. So we go back to a patient. So a patient, she underwent intestinal vaginoplasty using a section of the sigmoid. All right. So with that background, now we can start to understand, some of the presentations that she came with. So looking at the initial presentation of our patients, what differentials do we have? So the first one will be infections, either genital or enteric infections, depending on the sexual practices. Because the patient presented with bleeding from both the rectum and the vagina, we think about whether there's any possibility of bleeding disorders. Diversion colitis is an entity that is well described in patients who undergo diversion for one reason or the other, patients who have a stoma. So the stump or the residual stump, because of a lack of nutrients from diet, it tends to undergo some changes, which is known as diversion colitis. And one of the treatments for it is actually to supplement short-chain fatty acids, which are usually derived from diet and acted on by bacteria. IBD as well was a big differential. And although the patient didn't have the typical risk factors for ischemic colitis, which happen in an elderly patient with comorbids like diabetes, hypertension, atherosclerosis, that was also part of a differential just because of the surgery that they underwent, which involved manipulation of some of the vasculature. Drug-induced colitis is also an entity well described, especially for patients who are using NSAIDs, but because of the history of hormone therapy, for which we don't have a lot of evidence in terms of whether it can cause colitis. That was also one of our differentials. So in terms of the workup, So some of the significant labs showed an anemia, which was iron deficient, elevated CRP at 22. And in terms of looking for infections, the stool, microscopy, and culture are negative. Unfortunately, we didn't perform vaginal swabs, but the other tests, including renal and liver functions, were negative. And she also had an elevated stool fecal calprotectin of up to 4,000. So the next investigation was colonoscopy. So in terms of colonoscopy, there are particular features that we look for in terms of chronic inflammation. So as you can see, I mean, if you look at the normal colon, you'll actually be able to see very distinct blood vessels and also a very clear mucosal pattern of the blood vessels. But you can see there's a bit of blurring of the mucosal pattern as well as some areas which have absent mucosal pattern. So this pattern was in the rectum as well as mostly in the left-sided colon. But of course, there was a lot, I mean, there was alteration because of the previous resection that the patient has had. So we also did look at the vagina, the neovagina, and we saw, I mean, this exudate absence of, I mean, any blood vessels, as well as easy contact bleeding. So these were, I mean, features in keeping with the active, I mean, or chronic inflammation. And as I said, we still have differentials for that. So we also took biopsies to try and see what could be the likely etiology. So to understand the colon histology, so this is just a normal histology before we look at the findings in our patients. So as you know, the different layers of the colon, you have the mucosa, submucosa, muscularis, and serosa. And a zoomed up image of the mucosa shows, because it's an absorptive mucosa, the mucosa has been specialized in terms of increasing the absorptive capacity by having what we call crypts. And also looking at the cross-sectional image of the crypts, you can see that there are distinct crypts which are not combined. And then also there isn't, much in terms of inflammation in a normal colon. So if you compare that to what we found in our patient, where the crypts are actually very distorted and they seem to be budding, then you also have lots of inflammatory infiltrates, especially in the lamina propria. So the findings were both in the neovagina and also in the colon. So with this information in terms of the clinical history, the labs and the endoscopic findings, as well as the histology, so we're able to come up with a diagnosis of ulcerative colitis in the left-sided colon, as well as the sigmoid neovagina. So as I said, diagnosis of UC is not only one clinical diagnosis, but you need to have a constellation of multiple things like that in a patient. She had a family history of IBD. She presented with the typical symptoms. The endoscopic findings were more or less in keeping with chronic inflammation, as well as the findings on histology. So what did we do in terms of treatment? So we started induction with steroids. The aim was to taper over about 8 weeks. And we also gave topical, both vaginal as well as rectal mesalazine. And we also put the patient on oral mesalazine. And after about 8 to 12 weeks, we maintained on topical and oral 5 SI agents. But because she didn't improve much with the initial steroid therapy, we then started on a steroid sparing agent, which was azathioprine. So subsequently, she still presented with the recurrent bleeding, mostly from the vagina. And also she required multiple infusions of iron. So because of that, we deemed her not responding to the conventional treatment, and she's actually being evaluated for advanced therapy. In this case, we opted for infliximab, which we are still ongoing in terms of the process to put on the same treatment. So specifically about IBD and persons who are transgender. So the incidence of IBD in transgender is actually similar to the normal population. And as you said, active IBD is a contraindication for intestinal vaginoplasty, but our patient didn't have the symptoms at evaluation. And although there's a family history of the same, I said that wasn't evaluated initially because the guidelines only recommend a colonoscopy in patients who are above the age of 45. So that's something that we also need to, part of our recommendation was that patients who have an active history of, or a family history of IBD, or patients who are at risk of IBD, should undergo evaluation of the colon before it's utilized for vaginoplasty. And then in terms of hormone therapy, we didn't find any increased risk of developing IBD in either, supplementation with the masculine or feminine hormones, but there are reports of increased flare risk in patients who have IBD and put on testosterone therapy, that there could be a slightly increased risk of, flares in IBD. So this is actually my last slide, and we invite any discussion and any questions regarding our case. Thank you.